So lateral ligament complex consists of 4 parts. So I'll take my pen this. So this is my LUCL or lateral ulnar collateral ligament. Then goes your radial collateral ligament. Here is your annular ligament around your radial head, and there is a accessory lateral collateral ligament which goes from the annular ligament up to the ulna. But the most important is the lateral ulnar collateral ligament, which arises from lateral epicondyle and goes on to the crest of the basically the ulna, posteriorly goes towards the ulna, and this is the main stabilizer against your varus forces. So the primary stabilizer is your lateral to varus forces is your lateral ulnar collateral ligament. So you have to make a diagram of the elbow and show various basically the 4 ligaments, this one LUCL, RCL, annular ligament, and accessory lateral collateral ligament. These 4 ligaments you should be able to show with a diagram. Then comes your medial collateral ligament. Again, 3 parts of this. 3 parts are your, this is arising from the medial epicondyle, goes on to the supinator crest of the ulna. This is your anterior bundle of MCL. Then posterior bundle goes posteriorly, again from the medial epicondyle. Transverse bundle goes from the anterior bundle to the posterior bundle. So 3 parts of the MCL also, but the most important part is your anterior bundle. This is the primary stabilizer against your valgus forces. So primary stabilizer for valgus is your anterior bundle of MCL, valgus, and against varus forces is your lateral ulnar collateral ligament. Some accessory structures are there. So you have the quadrate ligament, which connects the inferior margins of ulnar ligament to the ulna. We already talked about accessory lateral collateral ligament, which connects or stabilizes annular ligament to the supinator crest, and there is a oblique cord which goes from lateral ulnar tubercle to the radius just below the radial tuberosity. So just remember, there are 4 parts of the lateral collateral ligament, 3 parts of medial collateral ligament, and maybe 2 accessory structures, which, and these 4 plus 3 plus 2 is 9 ligaments stabilize your elbow and make it a very stable joint. So if we are asked about more stabilizing factors, you can talk about primary and secondary stabilizer. Primary are your MCL, LCL, and the joint per se. Secondary stabilizers are your radial head, and the capsule, and dynamic stabilizers are Anconius triceps brachialis. Main, but what you were asked was ligaments of the elbow joint. So you have to tell in detail, make diagrams of both lateral side, one diagram for the lateral, one for the medial side, and tell all the 4 parts of the lateral ligament, 3 parts of the medial ligament, and 2 accessory ligaments. That's it. This is not required for your answer. Next part of question was, what is briefly talk about PLRI. So PLRI is nothing but posterolateral rotatory instability, in where there is a main injury is to your lateral complex, lateral ligament complex. So injury to the lateral ligament complex with or without any other bony injury is known as PLRI. It can be acute or it can be chronic. Hori's described a Hori circle of disruptions for PLRI, in which he talked about first, there is just in which the disruption of the ligament starts laterally and goes medially as the instability increases. The first part of that circle, first disruption, is PLRI, in which there is only a disruption or only injury to your lateral ulnar collateral ligament. Okay, second part leads to, so there is just part 2 of this Hori cycle would be a purged or a incomplete dislocation, and part 3 is where there is stage 2 is purged dislocation or incomplete dislocation, like this, and part 3 is, or stage 3 is, in which there is a full dislocation posterolateral, in which your MCL, anterior band of MCL may be intact or may become torn also, but Horry described as it as being intact. Rest all ligaments are torn, and flexor pronator origin may also be affected in this. So injury starts laterally with LUCL, then goes onto the anterior and posterior capsule, and then goes and affects your the medial collateral ligament. Stage 1 is only LUCL is affected, which is your posterolateral rotatory instability or subluxation, which is very subluxation. Part 2 is capsule disruption. Part 3 is your complete dislocation because of MCL rupture also. So usually how do you diagnose is basically there is in PLRI there is external rotation of radius and ulna in relation to the distal humerus. So there is rotatory instability. There is just a rotation, and this rotation of radius and ulna in relation to distal humerus leads to your rotatory instability or dislocation. How does a patient present? So clinical presentation is usually in chronic cases it's very vague. It's just pain, inability to do heavy work, unable to do bear weight on that elbow or upper limb, and maybe popping, snapping sensation. There may be a history of some prior surgery on that side, so history of prior trauma or surgery. Acute ones usually present with a proper history of trauma and usually able to see some dislocation or subluxation of the elbow joint. Clinically, the most important signs would be your pivot shift test, and the chair rise test is the one of the most practical examination which you do. You ask the patient to get up from the chair while bearing weight on the arm like this. So he bears the weight on the on his upper limb and tries to lift his body from the chair using his elbows as pivot, and this the patient complains of pain or inability to do so. You can do a draw test, lateral pivot shift test. All those are very difficult to do in a unanesthetized patients, much more easy to do in an anesthetized patient. You can do varus and valgus stress test in a supinated forearm. That is also described. So these various signs are described, but best diagnosis is usually done under anesthesia, or in radiographs you can get varus or varus stress x-rays done. MRI usually